Hello, this is Michael Altos, and we are recording Bearish Chapter 12, the Allergic Response, and this is Part 2. So let's talk for a few minutes about a perioperative allergic reaction. These reactions occur with an incidence of 1 in about 3 to 20,000 anesthetics, but with a mortality of about 4%, and 90% of these reactions occur within 5 minutes of administration of an IV drug, although they can be delayed by up to 20 minutes. So these are serious reactions that need to be identified and treated quickly. Histamine is one of the main players in allergic reactions. It is a naturally occurring amine which mediates inflammation and is secreted from mast cells and from basophils. Mast cells are perivascular, usually in the skin, lungs, and GI tract, and basophils are cells in the circulation. There are several histamine receptors. The H1 receptor, which I think of as the allergy receptor, is responsible for smooth muscle contraction in the respiratory and the GI systems. When this is stimulated by histamine, patients will have pruritus and sneezing. Release of nitric oxide will cause peripheral vasodilation and flushing. This receptor also will lead to a decrease in AV node conduction, and patients may develop bradycardia or coronary vasoconstriction. The H2 receptor, which I think of as the GI receptor, is primarily involved in stimulating gastric hydrogen ion secretion and may lead to some increased myocardial contractility and heart rate and some coronary vasodilation. The H3 receptor is basically a negative feedback receptor, and when histamine binds to it, it inhibits further histamine synthesis and release. Now, before we go any further, we should clarify that the term anaphylactic, which we will discuss in a little bit, and the term anaphylactoid used to be two separate terms. And people would talk about anaphylactoid, which is really just a non-immunologic release of histamine due to activation of mast cells. Instead of being immune-mediated, where there's this snowball effect, it's non-immune mediated and is more of a dose-dependent effect. Patients who are at risk for an anaphylactoid or a non-immunologic anaphylactic reaction can be pre-treated with antihistamines, and certain substances that are known to precipitate these sorts of reactions include antibiotics like vancomycin, certain hyperosmotic agents, neuromuscular blocking agents like atracurium and mivacurium, opioids like morphine, meperidine, and codeine, and certain thiobarbiturates. So now that we've talked about both immune and non-immune mediated anaphylactic reactions, let's explore anaphylactic reactions in a little more detail. First of all, as we said before, patients need to have some prior exposure to the antigen. This allows the creation of IgE antibodies specific to that antigen, and with re-exposure they will cross-link and begin this immune reaction. Mast cells or basophils will then release histamine, as well as other vasoactive substances like tryptase, leukotrienes, and cytokines. Patients will experience bronchospasm and upper airway edema, vasodilation, capillary permeability, hypotension, and even potentially circulatory collapse. Their skin will show urticaria, flushing, and swelling or edema, and these symptoms can persist for more than 24 hours. Here are some different slides which all show examples of hives. So we see that hives can take on a number of different clinical manifestations. How do we manage anaphylaxis? Well, the first step is to limit or stop administration of the antigen if possible. We want to do our ABCs, make sure we maintain and evaluate the patient's airway, and administer 100% oxygen. It's strongly recommended that we stop inhalational anesthetic drugs until we can confirm the patient is hemodynamically stable. Most of these patients will require a tremendous amount of intravascular volume expansion. They may need liters and liters of fluid, as up to 40 or 50% of their intravascular volume can be lost due to leakage into the interstitial space. Studies have shown that crystalloid and colloid are equally acceptable for this sort of resuscitation. The most important drug in the treatment of life-threatening anaphylaxis is epinephrine, which serves several goals, including restoring membrane permeability and reversing bronchospasm. The alpha effects of epinephrine will increase the patient's blood pressure, whereas the beta effects will help with bronchodilation. Large doses of epinephrine may be harmful, and we recommend that you start with the smallest dose effective for the patient's condition. You may start with 5 or 10 micrograms IV and titrate up as high as 1 milligram as needed if the patient arrests. An alternative is to give epinephrine sub-Q or intramuscularly, especially if the reaction is not quite so life-threatening. The advantage of this is you get a slightly longer duration of action, and while your onset of action may be a little slower, you won't get the peak in epinephrine levels that leads to the tachycardia and hypertension that we so often see. 300 to 500 micrograms is a reasonable dose when administered by this route, and keep in mind that an adult EpiPen has about 300 micrograms of IM epinephrine in it. Don't forget you can also use epinephrine as an infusion in the typical range of 0.05 to 0.1 micrograms per kilogram per minute, and this may be especially useful for a persistent anaphylactic reaction. Once we've treated the patient with oxygen and fluid resuscitation and epinephrine, we can consider other possible adjunctive treatments. For example, antihistamines like diphenhydramine at a dose of 0.5 to 1 milligram per kilogram. This will help with the large amount of histamine that's been released. Remember to give it slowly so patients don't have an antidopaminergic hypotension. And remember that this only helps with histamine-mediated responses, but won't help with any responses due to leukotriene, like negative inotropy and bronchospasm. Many people also give H2 blockers. The indications for this are unclear. Most people feel that it doesn't hurt, but the data that it helps is questionable. Other treatments you may want to consider include bronchodilators like beta-2 agonists such as albuterol, corticosteroids, which admittedly will not help immediately, but may help with a second phase of anaphylaxis that may occur down the line. Corticosteroids may also help enhance beta-agonist drugs, and they're usually given in a relatively large dose of anywhere from 0.25 to 1 gram IV of hydrocortisone, or even 1 to 2 grams of methylprednisolone. Other treatments include sodium bicarbonate for acidosis, and patients who have persistent hypotension and refractory shock may benefit from norepinephrine or vasopressin infusions. Diagnosis of a perioperative allergic reaction is really a clinical diagnosis, and you should not delay treatment waiting for more objective tests or signs to develop. However, you may find it useful to send labs to confirm the diagnosis in order to help with management of future anesthetics. Labs should be sent on ice, and the two labs we're most interested in are plasma histamine and serum or plasma tryptase. The histamine peak levels occur in a very narrow window of only about 10 to 30 minutes after the event begins, and this should be drawn in an EDTA lavender tube or else a citrate tube. Tryptase levels peak at the 60 to 90 minute mark and may persist for up to 5 hours. This should be drawn and placed into a red top tube or an EDTA lavender tube or else any heparin or citrate tube. Again, these should be sent on ice to the lab. Subsequently, patients should be sent for potential skin testing, RAST, or ELISA testing to confirm and identify the cause of their allergic reaction. We'll stop the video here and pick up again in the next video with more discussion about the allergic reaction.